Session 7 is continuing with the common medical disorders associated with pregnancy. This session will describe the common medical disorders in pregnancy. We have discussed some already, so we want to continue with the discussion. Now I want to talk about women who prior to pregnancy had underlying medical conditions may have the condition being exaggerated, like we said in the previous session. And this session will discuss metabolic and autoimmune conditions that may complicate pregnancy. At the end of the session, the student will be able to outline common medical conditions. We describe the effects of the condition on the mother and the fetus like we did in the previous session. We want to describe the management of these conditions during pregnancy and describe the treatment adjustments. And that's our reading list. We want to start with diabetes and pregnancy. Diabetes mellitus is a chronic and progressive disorder that affect the normal metabolism of carbohydrates, fats, and protein in the body. It is characterized by hyperglycemia resulting from defects in insulin secretion or insulin action, or both. This is just a brief pathophysiology. I know you've done medicine and you've done diabetes already, so we don't want to waste too much time on this pathophysiology. Now, hyperglycemia is usually the result of insulin deficiency when there is high secretion of hormones antagonistic to insulin function. And severe hyperglycemia, greater than 22 millimoles per liter, may lead to diabetic ketoacidosis, coma, or death. The cardinal signs: you can have polyuria, you can have polydipsia, and unexplained weight loss. Type 1 diabetes. This occurs when the beta cells in the islets of Langerhans in the pancreas are destroyed, stopping the production of insulin. So because here the production of insulin is affected, there is a need for insulin therapy. In type 2 diabetes, it occurs as a result of defects of the action of insulin. There is no problem with the production of the insulin. So insulin therapy is not always needed because the islet of Langerhans, the beta cells in the islet of Langerhans is adequate and is able to produce enough of the insulin. Gestational diabetes. This is a result of carbohydrate intolerance resulting in hypoglycemia of variable severity with its onset or first recognition during pregnancy. So in gestational diabetes, we are saying that this person was not a diabetic, but then for the first time in the woman's life, she is experiencing diabetes as a result of the pregnancy. We want to just look at the pathophysiology, not of diabetes mellitus in general, but as it occurs during pregnancy. So pregnancy increases the levels of estrogen and progesterone. We know they are the main hormones of pregnancy. And then prolactin. We know that prolactin is also produced so that after delivery we to be able to manufacture enough milk for the baby. So during pregnancy, the increasing levels of estrogen and progesterone and the prolactin will produce a progressive hyperplasia of pancreatic B cells. And because of the hyperplasia, it will result in secretion of 50% more of insulin. So there is hyperstimulation of the beta cells, and then they are forced to increase the production of the insulin. Now, when they have forced the beta cells to increase insulin production to very high levels, then other hormones also in pregnancy, which are the human placental lactogen and cortisols, they also fight against the glucose being absorbed very fast. And because of that, there is so much glucose, and then this glucose can be found in the mother's blood, and she is diagnosed as having gestational diabetes. Now, this physiology is useful because this physiology enables large quantities of glucose to be taken up by the maternal circulation and transferred through the placenta to the baby. So after they have triggered the beta cells to increase insulin production, they also release other hormones that will also minimize the conversion of the insulin, so that more insulin will always be available in maternal circulation. And that is the only way we can have a lot of glucose being taken to the baby. Gestational diabetes is most likely to emerge when the extra demands on the pancreatic beta cells precipitates glucose intolerance. So if it remains within the normal physiological bounds, then there is no cause to worry. But there are times that there is an extra demand, and this may precipitate what we call glucose intolerance, and diabetes occurs. For the risk factors, if the woman had a previous delivery where the baby was weighing greater than 4.5 kilograms, then you should suspect that it might have been gestational diabetes. If the woman had a BMI greater than 30 kilograms or a family history of gestational diabetes, then you suspect that she could develop diabetes during pregnancy. To diagnose this condition, you look for the symptoms of excessive thirst, increased urine volume, sudden weight loss. Remember that in pregnancy, we could have increase in micturition or polyuria that is physiological. So if it becomes very excessive, then we'll go on to diagnose diabetes. So you should be able to appreciate that this woman, by virtue of pregnancy, weight is pressing on the bladder, so the bladder capacity is reduced. So she will be urinating normally at very short intervals. So you look for other signs like the excessive thirst, like the increased urine volume, and then the sudden weight loss. And remember that the urine too will be lost most of the time at night. Blood glucose check. You can't just use the signs and symptoms. Some women have exaggerated signs of physiological signs of pregnancy, and they may show all the symptoms. So you have to do a blood glucose check, and this will confirm if the mother has the condition or not. So you do random venous plasma glucose concentration test, and then fasting plasma concentration test, and then you can also do a 2-hour plasma concentration test. Remember that in pregnancy, we don't allow these women to fast for very long periods. So most of the time, the random check may help. Or on few occasions, when it is very severe, then they may do the fasting plasma concentration with all the precautions that it deserves. Without symptoms, the diagnosis could be based on a single glucose test, but requires confirmatory plasma venous determination taken on another day. So if the woman comes to the antenatal clinic and you find she has sugar in the blood, you don't just go ahead to diagnose the woman of having diabetes. There is a need for you to take blood sample again and really monitor if it is even diabetes, what is the extent and what the treatment should be. In our management, we talk about preconceptual care or interconceptual care. If this woman is a diabetic before she's embarking on pregnancy, there is a need that she controls the diabetes to some tolerable levels before she starts the journey of pregnancy. If not, if she is a diabetic and we are saying that pregnancy could predispose her to developing diabetes, then she could experience very high forms of diabetes. So preconceptual care is done before the woman embarks on pregnancy. Now, if she has a child and is going to have another child, then we do what we call the interconception care. So it means that she's had a child. Between that child and another child, she's coming for a special care where we control the glucose levels before she embarks on the new journey. Establishing a good glycemic control is important. Women with type 1 DM will need their insulin therapy reviewed. If she was a diabetic and is now pregnant, they will have to review the treatment because the doses she was taking before pregnancy may not be tolerable during pregnancy. And women with type 2 DM with poor glycemic control will require insulin during pregnancy. And then folic acid supplements, 5 milligrams per day is required. And then capillary blood glucose testing should be encouraged. We may do a renal function test. Smoking should be strictly discouraged. And then assess body mass index and correct where necessary. Gynecological examination for vulvar warts should also be carried out. At the antenatal level, look at blood glucose levels, 2 to 4 weekly visits until 28th day of gestation, and then 1 to 2 weekly until 10 to maintain good glycemic control. So realize that if the woman has diabetes or developed diabetes in pregnancy, we increase the number of times she should come to the antenatal clinic so that we monitor her very closely. Dietary advice and monitoring is continued, and the pregnant woman is advised to take high fiber diets. Make patient and family aware of hypoglycemic symptoms so that she can report if they occur. And then treatment includes 3 to 5 glucose tablets or 250 to 300 ml Isotonic lucozade or 75 to 120 ml carbonated lemonade. So depending on the level of glucose that was found in the blood, adjustments are made accordingly. Now, during delivery, if you're going to deliver any woman who has diabetes, you prepare extra to receive this woman and the baby. Routine induction of labor or planned cesarean section before term is not recommended, as it is more likely to result in neonatal respiratory morbidity. Induction of labor may be considered after 38 weeks if fetus is considered to be macrosomic, meaning that the baby is too big. So if the baby weighs about 4 kilograms whilst in utero, we may prepare to have cesarean section done. You maintain a normal glycemic level in labor throughout by the use of insulin infusion. So as they are delivering, they have insulin infusion, and we also continue monitoring the blood glucose, and then we titrate according to the blood glucose levels. So it means that we will adjust the flow of the fluid depending on the level of the glucose in the blood. Capillary blood glucose level should be assessed, and then we do a continuous tomography monitoring so that you assess the fetus condition, and fetal blood sampling is also necessary if acidosis is suspected. When this woman delivers, remember that it is not over. You discontinue the insulin and glucose therapy immediately after delivery, or you decrease the insulin infusion to 50% after delivery for 24 hours. We do all these things depending on the glucose levels in the blood. So there is a continuous monitoring of the glucose level, and depending on what is found, then you do the adjustments accordingly. And the postpartum hemorrhage, we administer antibiotics, especially if we had operative births, and then breastfeeding is encouraged. But because of increased nutritional demands, an extra 40 to 50 grams carbohydrate per day is advised. Women with diabetes should be reviewed at 4 weeks interval and should have glucose tolerance tests. You examine the baby fully for any abnormalities. Any baby born to a mother with diabetes have a higher tendency of developing some chromosomal abnormalities, so you observe the baby. And then sometimes you might have missed these things during the antenatal visits. We've talked about early breastfeeding. You check for polycythemia and hypocalcemia. You assess the hematocrit level of the fetus, and then if it is greater than 70%, exchange blood transfusion may be required, so that we take off all the baby's blood as you are replacing with another blood. The maternal complications, we have ketonuria, we have nephropathy, retinopathy, spontaneous abortion could also occur, and there's also a condition referred to as diabetic neuropathy, and sometimes they could develop coronary heart disease. We said earlier on that any condition that affects the woman once the baby is in utero, it also has fetal complications or fetal implications. So for fetal complications, we have fetal growth disturbances, and it could be, sometimes they can have low birth weight, but normally they become macrosomic or very big. And their head can also become very big, so it can have cephalopelvic disproportion. Asphyxia and trauma during labor will occur because the baby is very big. you try to maneuver, and this baby can get shoulder dislocation because the baby is big and we are trying to force the baby out. Respiratory dysfunction after birth most of the time occurs in babies born by diabetic mothers. You could have cardiac abnormalities. They also have polycythemia, neural tube defects, caudal regression syndrome, and then sometimes you also experience stillbirth. Some of the babies become hypoglycemic just around the time of delivery, and then they are born dead. These are references, and this brings us to the end of medical conditions in pregnancy. I have said earlier on that there are a lot of medical conditions in pregnancy. Every condition that occurs in any other person can also occur in pregnancy, all types of infections, but we just treated the ones that are very common in Ghana.